Thank you for joining us for Conversations and Cases, integrating recent progress in the treatment and management of relapsed refractory multiple myeloma. During this segment, we'll be discussing a 60-year-old patient with early relapse and high-risk cytogenetics who is physically fit. I am Dr. Jesus Berdeja. I'm the Director of Multiple Myeloma Research at the Sarah Cannon Research Institute, and I'm very happy to say I'm joined by my colleagues, Drs. Paul Richardson and Saad Usmani. We'll start with the case. This is a 60-year-old patient who was diagnosed with multiple myeloma 15 months ago. The patient at that time had high-risk cytogenetics, which included translocation of 414 and a duplication of chromosome 1q. The patient underwent treatment with RVD induction, followed by autologous stem cell transplantation, then underwent maintenance with lenalidomide and bortezomib. Unfortunately, just 15 months into maintenance, the patient started to progress with an elevated serum M protein and a bone marrow biopsy showing 30% plasma cells, and now FISH showing a 17p deletion as well. The patient is fit. They're actually relatively asymptomatic and are asking what's next. So in this scenario, we have a patient who is fit, who has traditional high-risk features, which I'll remind you are 414 translocation, 1416 translocation, and 17p deletion as part of the revised ISS stage group. But also this patient is now relapsing within 2 years of initial treatment. And so we are starting to notice this group of patients that we're calling functional high risk, which are patients that, regardless of their cytogenetic risk, are not maintaining the remission as long as we would expect. And so this patient definitely would be categorized as high risk. So in this scenario, this patient, I'll remind my colleagues, because I would like for them to comment on what we would do next for this patient. This patient is progressing early. They have been on lenalidomide and bortezomib maintenance, and now they are progressing. So perhaps I will go to Dr. Usmani, who I believe is, as we all regard as one of our experts in high-risk disease, as to what he would do next for this patient. How would you approach him, Saad?
No, thank you so much, Jesus. As you clearly outlined, this is a patient who is acting like a functional high-risk patient, relapsing, shortly, within the time period of their initial therapy. And then, I think the key things that we also have to pay attention to as we restage this patient, is the kind of karyotypic abnormalities they actually have, whether they have any circulating plasma cells or extramedullary disease. So, doing a PET CT scan and looking at the peripheral blood, becomes, very important. For someone like this, and on top of, relapsing very quickly, they're clearly lenalidomide refractory as well. So this is the kind of patient, where, having a quadruplet, induction, would be appropriate. And the goal would be, to try to get these patients to a good response plateau. This is the kind of patient where a PI IMiD-based, maintenance strategy also comes into play. And I have to say that, we are going to be extrapolating a lot of data, because we only have, single arm studies, phase 2 studies informing us on what would be the best approach for someone like this.
Thank you, Saad. And I think that's a good disclaimer for the audience that this is a unique scenario. It's a very high risk scenario, and so a lot of the things that we may be discussing may not be what's currently considered standard of care or FDA approved indications. Paul, in terms of going sort of to what's available if you don't have a clinical trial, for example, what combination do you think would be what would you go to next in this patient who's
I would Very, very much echo Saad's comments. I think the issue here would be a quadruplet if one could put that together and insurance would allow it outside of a clinical trial based upon what we've learned from our single-arm experiences with the caveats that you so nicely framed, Jesus. And I think the construct of a PI and IMID appropriately dosed steroid and an antibody absolutely makes sense, dependent on what's, of course, been previously given and what the patient's relapsing on. But the idea of a quadruplet to me is very attractive for this patient. And our own work in that regard, I just want to especially acknowledge my colleague Andy Yee, who's led our trial of KPD plus daratumumab in this high-risk group of patients. And, reported at ASCO last year in 2022 was a 95% response rate with early maturity, but nonetheless a one-year PFS estimate that was very exciting. Obviously, in the clinical trial space, there are lots of options, and I would obviously point to the BCMA platforms as being incredibly exciting for higher risk patients in this setting as well.
Before we go on to sort of some of the more clinical trial options or less standard options, in terms of the triplets that we have, there was some very interesting data that was presented by Dr. Martin at ASH of the IKEMA trial and a subset analysis in early versus late relapse patients. And I'm curious if you had to go to a triplet, would you all consider the DARA or isatuximab carfilzomib combination? Is it preferable to a DARA combination or others? Dr. Usmani.
So that's a very interesting question. I think it's important to appreciate the mechanism of resistance when it comes to the 1Q question. From a mechanistic standpoint, I don't see a lot of difference between isatuximab as a single agent and daratumumab, with caveats of different epitopes and perhaps the immunomodulatory effects, as well as different perhaps preclinical differences in how the direct cell kill happens with each of these anti-CD38 monoclonal antibodies. With 1Q, the key issue is proteasome inhibitor sensitivity or resistance. And that's where I think, what we see the benefit, and the synergy is, exist with carfilzomib. 3 copies of 1Q tend to be bortezomib resistant, whereas, 4 or more copies, 4 copies can still be sensitive to carfilzomib, and there's preclinical rationale and data that has been shared. Obviously, with the ISA-KD, we actually had a high proportion of patients with 1Q, which afforded that subgroup analysis showing really, good results. And I think, both, Dr. Richardson and Martin have presented on those data. In my mind, it's the anti-CD38, doesn't matter as much as the choice of proteasome inhibitor when it comes to the 1Q population.
Yeah, I completely agree, Jesus, with that, because I think Saad nailed it, and I particularly like your analysis, Saad, on the 1Q question. I do think isatuximab, particularly if this patient, say, had prior DARA exposure much earlier and had come off DARA, would be a really interesting go-to. I mean, we do think of them as qualitatively different. There's the difference in the epitope binding, and then preclinically, there's quite interesting differences in terms not only of the immune milieu that's modulated by the antibody, but also by the apoptotic killing, the mechanism through the lysosomal and ectoenzymic pathway for isatuximab. May be more powerful preclinically than daratumumab in the same sort of model systems, but being careful not to make too many leaps of faith. I think the IKEMA data are quite compelling, actually. I would wholeheartedly agree with Saad.
Excellent. Thank you. That's excellent conversation. So to move on a little bit, so as we know, there's some early data now from both cilta-cel and ida-cel in the early cohort data with KarMMa-2, cohort 2A, as well as CARTITUDE-2, cohort B, with in patients with this same scenario that we're just talking about, with excellent response rates. And I guess to Dr. Richardson, I would ask you, if you had the option or a trial, would you go next to a BCMA therapy, directed therapy?
I think so. I mean, I think the CARTITUDE-2 data from the cohort B experience presented by Niels van der Donk at ASH in December are just remarkable. I think obviously patient selection in CAR-T platforms is really the key. And for the fitter, healthier, younger patient, this is obviously incredibly encouraging. Very different in a frailer patient, in my opinion, and very different in someone who may be a significantly older. But in this kind of high risk, relatively young, fit patient, it's extremely compelling to see this kind of data from CARTITUDE-2. And for that matter, also I'm also frankly struck by some of the bispecific data as well. That is particularly exciting, just to especially acknowledge Saad's leadership of teclistamab, as well as, of course, other up-and-coming targets, both from the standpoint of CAR-T and bispecific therapy, in terms of the GPC5RD target and so on, in other words, talquetamab. But you see my point, as I would be really interested in this high-risk population being able to exploit either CAR-T or T-cell redirected therapy.
Yes, no, I agree. Dr. Usmani, further comments on that?
No, I agree with Paul's comments. One interesting caveat that I'll share, and it's not relevant to this particular juncture in this patient's journey, but I think what we learned from the commercial ida-cel experience, there was an 11 multi-institutional experience that was shared. I was very impressed with the response rates that were reported, 88% in the non-BCM exposed patients in the commercial experience. So I really wonder, what the real world implications would be when both of these options become available to our early relapse patients. I think, I'll really look forward to that. Cilta-cel, in clinical trials certainly appears to be, fairly active, but having both those options available, I think, for our patients, given all the logistic issues we have with slot allocation, I think would be important.
Yes, no, I completely agree with you both. And I would also add that, now there are combination studies. So for example, this patient that hasn't seen an anti-CD38, wouldn't it be great to be able to give them an anti-CD38 antibody and a BCMA bispecific antibody combination therapy? So hopefully that data it's definitely being generated now, but hopefully it'll be available for us. And so in the next year or two, when we're having this discussion, we can actually discuss some standard approaches for this type of patient who obviously is quite complex. So I think I'm actually going to wrap this up. So thank you again for joining us for this segment on a 60-year-old patient with early relapse and high-risk cytogenetics who is physically fit. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credits, access supplemental slides, as well as other topic segments and case scenarios. And again, I would like to thank my colleagues, Drs. Richardson and Usmani.